CSF analysis made easy. A 24-year-old patient arrives with fever, severe headache, neck stiffness, and confusion. A lumbar puncture is performed, and now the CSF report is in your hands. This isn't just a lab report. It's a crime scene. Every value is a clue. Your job is to follow the evidence and uncover the diagnosis. Is it bacterial meningitis, viral, tuberculous, or fungal? The answer is already there. You just need to know how to read the clues. Let's solve this case together. Clue number 1. Opening pressure. Opening pressure is the pressure of the cerebrospinal fluid at the moment the lumbar puncture needle enters the subarachnoid space. Normal opening pressure in adults, 10 to 20 centimeters of water. Now comes the important question. Is the opening pressure when the opening pressure is raised? Think of conditions that increase pressure within the subarachnoid space. The usual suspects are bacterial meningitis, tuberculous meningitis, fungal meningitis, and increased intracranial pressure. Viral meningitis is not ruled out, but less likely. But opening pressure alone isn't enough to identify the culprit. We need our next clue. Appearance. Our second clue is the appearance of the CSF. Simply look at the fluid. Sometimes the diagnosis is right in front of your eyes. So, what do you see? A hazy appearance suggests mild inflammation as cells and protein begin to rise. Turbid or cloudy CSF indicates a heavy inflammatory response, making bacterial meningitis more likely. A yellow, xanthochromic appearance usually points toward blood breakdown, such as subarachnoid hemorrhage, rather than meningitis. Let's start with the easiest one. Clear CSF. A clear CSF doesn't solve the case. It simply tells us that pus, blood, or heavy inflammation is unlikely. To find the real culprit, we need more clues. Our next clue is the cell count. First, ask yourself a simple question. Is the cell count normal or is it increased? If it's increased, don't stop there. Identify which cells are dominating. That's where the real clue lies. So who's at the crime scene first? Neutrophils or lymphocytes? If neutrophils dominate, think bacterial meningitis. If lymphocytes dominate, consider viral, tuberculous, or fungal meningitis. That narrows our suspects, but we're still left with 3 possibilities. To find the real culprit, we need our next clues, protein and glucose. Our next clue is protein. Think of it as a sign of how much inflammation has disrupted the blood-brain barrier. Is the protein mildly elevated or markedly elevated? The higher the protein, then the more likely the blood-brain barrier has been disrupted by significant inflammation. Markedly elevated protein makes us think more strongly about tuberculous or fungal meningitis. We have one final clue left, glucose. And this clue often confirms the diagnosis. If the CSF glucose is low, it tells us that something inside the CSF is consuming glucose. So, who are the glucose thieves? Low glucose points us toward bacterial tuberculous and fungal meningitis. Viral meningitis usually has a normal CSF glucose. Now let's put all the clues together and solve the case. Prime suspects identified. Bacterial meningitis has a distinct pattern. Viral meningitis has another, but tuberculous and fungal meningitis often look very similar on CSF analysis. That's when you need the next level of investigation. One final note. CSF analysis narrows the diagnosis, but confirmation may require microbiological tests.
You must be crazy if you think that I'ma slow down. Don't wanna hear it talking shit, fuck the drama. Keep it coming, I'ma send you to your mama.
Keep following the clues. Follow Capsule for medicine beyond memorization.